non-cardiac surgery, Dr. Himanshu Yadav, consultant interventional cardiologist at Shantived Institute of Medical Sciences, Agra, will be in action for the next 10 minutes. We'll have a combined discussion at the end for the last 8 minutes. Dr. Yadav, please, your timer is straight across. Thank you.
A very good morning to all of you, respected chair and all the faculty. Thank you for inviting me for this session. So I'll just start it. This is one of the most important topics, most neglected topics, and this is one topic which gives a cardiologist more importance amongst our colleagues of different fields. And it is, I would also say that it is a topic of nuisance that we face day in and day out. Anyways, so let's start it. Preoperative cardiac evaluation in non-cardiac surgery. How do we go about it? So, non-cardiac surgery is associated with a complication rate of around 7 to 11% with a mortality rate of around 1%. And up to 40% of these are caused by cardiac complications. So we all have faced it. Patient dies due to whatever cause. At the end, cardiologist is called in the ICU. They make us stand in front of the attendant and say cardiorespiratory arrest ho gaya. So it is a nuisance that we all of us face day in and day out. So cardiac complications after non-cardiac surgery depend mainly on three factors. One is the type of surgery, that it is a low risk, intermediate risk or high risk surgery. Second is the patient related risk factors and on the circumstances under which it takes place, that it is a urgent surgery, emergent surgery, or it is a time-based surgery. So there are hemodynamic changes during surgery which cause a stress response and therefore this stress causes increased myocardial oxygen demand and therefore surgeries is a inciting factor for ACS. So a stepwise approach is that first thing that we have to see is that it is what type of surgery it is. It is an urgent surgery or emergent surgery, or it is urgent surgery. Emergent surgery is something which has to be done within 6 hours. If not done, it can lead to life or limb loss. In such cases, no cardiac evaluation is required. It is not so that patient should be held upon that first cardiologist will evaluate, give a green signal and then we will go ahead with the surgery. Legally, you can say that in such cases, I was working at a center which was a very high volume neuro center where we had lots of road traffic accidents, head injuries, and I was called that attendants were told that cardiologist is not there, so we are not able to go ahead with the procedure. And I said that it is a legally, you can go ahead with the procedure and it is not required. So in urgent and emergent cases, when there is threat to life or limb within 6 to 24 hours, cardiac evaluation should not be a cause for delaying or waiting for the procedure. So what it says, cardiovascular risk and surveillance for cardiovascular events usually without performing additional tests to avoid any delay in surgeries. When there is time sensitive procedure or elective procedures, here comes the role of cardiologist in pre-cardiac evaluation. So good practice statement, this is Canadian Cardiovascular Society guidelines. These are the latest guidelines on this topic. It clearly says that in patients who require emergency surgery, we recommend against delaying surgery for a preoperative cardiac risk assessment. In patients who require urgent or semi-urgent surgery, we recommend undertaking preoperative cardiac risk examination only when there is potentially undiagnosed severe obstructive intracardiac abnormality, either severe MS, severe AS or pulmonary hypertension, which is either patient gives history of this or there are clinical markers that suggest such diagnosis. And in patients who undergo elective non-cardiac surgery who are 45 years of age or older or 18 to 44 years with known significant cardiovascular disease, we recommend they undergo preoperative cardiac risk assessment. So in urgent and emergent cases it is not required, and in cases who are more than 45 years of age or between 80 to 44 but are a known case of some cardiac disease, in those cases preoperative cardiac assessment is required. Step 2 is, one was if there was an urgent surgery, no need of cardiac evaluation. Step 2 is that you have to see, does patient have an active cardiac disease like it is a ST elevation MI, non-ST MI or cardiac failure, then forget about the surgery, manage the cardiac part first. So If it is an emergency surgery, forget about the cardiac part, do the surgery. And if it is a ACS, CHF, ventricular arrhythmias, forget about the surgery, manage the cardiac part first. So, urgent surgery, no need of cardiac evaluation. ACS, CHF, ventricular arrhythmias, no need of surgery. Now, we just should know about low risk, intermediate risk, high risk. Low risk are like cataract surgeries, endocrine, thyroid, dental, breast. We all have done stress echos before a patient goes for a cataract surgery, and I hated doing it because people don't know that cataract is a low risk surgery, does not require any pre-cardiac evaluation, does not require. So please tell your counterparts next time that please don't send such patients for pre-op cardiac evaluation for cataract and all those things. So most of the surgeries come in the intermediate category. So step 1 and step 2 I have told that step 1, if it is emergent, urgent surgery, no need of cardiac evaluation. If it is MI, ACS, CHF, then no need of surgery, delay the procedure, first treat the cardiac problem. Now third is low risk, intermediate risk or high risk. Again, if there is a low risk surgery, for example cataract, dental, breast, thyroid, no need of any cardiac evaluation, go ahead with the surgery. Let's presume that most of our patients are of the intermediate or high risk surgery. Then we just have to ask one simple question to the patient. In my pre-operative cardiac evaluation, I always write it on my prescription paper that patient says that he or she can walk 2 flights of stairs without any discomfort. That's all. Nothing more required in pre-operative cardiac evaluation. If patient says that, then notably when capacity is high, the prognosis is excellent, even in the presence of stable ischemic heart disease or risk factors. He might be a patient of cardiac disease, he might have plethora of risk factors, but if he can walk 2 flights of stairs without discomfort, he says that categorically, then we don't need to stress upon unnecessary test. The majority of patients with stable heart disease can undergo low and intermediate risk surgery without additional evaluation. So this was step 4. Now step 5, patient says, or we do not know that patient can walk 2 flights of stairs or not. That means the level of exercise is less than 4 meds, or we do not know. Then we move ahead to see what are the other risk factors in this patient. So here we come to the step 5, that is the RCRI, revised cardiac risk index. We have to see, I write a statement on my prescription paper, no history of ACS, CHF, CVA, diabetes and stroke. That's all. So ACS, it includes both MI and angina, CVA, stroke, CHF, heart failure, diabetes and renal insufficiency, that is creatinine more than 2. So you have to just, it is on my spinal reflex that these are the RCRI risk score that I have to see. So if RCRI risk score is more than 1 and the patient working capacity is less than 4 meds, that is when we have to go ahead with further tests like ECGs, echos and all those things. Up tak, if it was a clear slate, there was no need of any unnecessary investigation. So now we come when the capability of exercise of a person is less than 4 meds and RCRI risk score is more than 1. Then we require other diagnostic tests like serum biomarkers, electrocardiogram and non-invasive imaging cardiac test may represent an important added diagnostic prognostic value in evaluation of patients with RCRI more than 1 and or meds less than 4. So echocardiography, when to do, patients with functional capacity less than 4 meds and or more than 1 risk factors of RCRI. Patients with signs and symptoms of heart failure or patients with known LV dysfunction. Routine echocardiography is not recommended for preoperative cardio evaluation. So that is why I call this a nuisance, because we all know that all the departments send echos to us routinely without applying much of the minds. So when to do stress test in these patients? Are we enough with ECG and echo? We all know that CAD is difficult to diagnose with ECG and echo. If there is significant problem finding we see in ECG and echo, or secondly, if there are more than 2 RCRI risk factors, 3 or more risk factors are there, then we can go for stress tests like stress echocardiography or treadmill test. Talking about NT-proBNP level, this is from Canadian guidelines. It says that all patients who are more than 65 years of age should get a NT-proBNP test done before surgery, and those who are RCRI more than 1 or meds less than 4, they also should get a NT-proBNP test done. Coronary angio before surgery, the indications are same. If the patient has ACS, MI, then go ahead with coronary angio, otherwise not. So urgent surgery, yes. Don't forget about cardiac evaluation. Patient has MI, CHF, ventricular arrhythmia, forget about surgery. Third, determine if it is a low risk surgery like cataract, breast, thyroid, no need of cardiac evaluation. Fourth, if patient can walk 4 meds, no need of further tests. Fifth, if patient has less than 4 meds, then calculate the RCRI risk score. If RCRI is more than 1, then and meds is less than 4, do the ECG, echocardiography, and if there are multiple risk factors, do a stress test. Thank you. Time is 0.
Thank you. Thank you very much, Dr. Yadav. With the permission of the chair, we'll move on to the third presentation. We'll have a combined discussion at the end that features patient with musculoskeletal symptoms on statin therapy, how to manage. Our invited speaker for the next 10 minutes, Dr. Naveen Jambwal, Professor of Cardiology at Dr. Ram Manohar Lohia Institute